Good evening, everybody. I will talk today about how to approach clinically atotic child. Of course, we know ptosis is just dropping of the upper eyelid, but when you approach a case of ptosis coming to your clinic, you have to make sure it's actually ptosis. So you have to exclude it's not brow ptosis, it's not an orbital mass, especially a lacrimal gland mass, it's not due to dermatochalasis, and of course, it's not due to contralateral lid retraction. Ptosis can be classified into acquired and congenital ptosis. Of course, congenital ptosis is much more common, and it can also be acquired according to the cause, into neurogenic, myogenic, aponeurotic, mechanical. We will go fastly through the most important causes, and I will give you one clinical sign which is characteristic to each cause. Like here we have third nerve palsy. Of course, the most characteristic feature will be the ophthalmoplegia. In case of Horner syndrome, we all know that it's red of Horner syndrome. In case of third nerve misdirection, the most characteristic feature is that we can find bizarre movement of the upper lid with moving the eye to different directions of gaze. Another important thing that should not be missed is Marcus Ganjo winking. Usually the patient would not tell you that he is moving his eyes while masticating or while eating unless you ask specifically for this. And sometimes it's annoying if you correct the ptosis and leave the child post-operatively still having the same problem. So you have to ask for it and you have to target it in your treatment. Myogenic ptosis, like cases of myasthenia gravis, the most characteristic feature here is that ptosis usually worsening at the end of the day, and you can easily correct it in your clinic by simply applying some ice pack test. A small bag of ice into the eyelid would improve the condition. Myotonic patient characterized by the mournful expression and the difficulty relaxing grip. They say that these patients, when they are riding the bus and holding roughly in the bus, tend to miss their station. Another cause is ocular myopathy. This is characterized by slowly progressive symmetric ptosis. And here you have to check for some significant diseases like Kearns-Sayre syndrome. These patients tend to have heart block, second-degree heart block. So when you're doing surgery, you have to take care of this point and refer the patient to a cardiologist before the surgery. Cases with aponeurotic ptosis, mainly involutional or post-operative ptosis. The characteristic feature in aponeurotic ptosis is that these patients have good levator function. Usually, they have very high lid crease, deep superior sulcus, and sometimes thinning of the lid. As you can see here, you can almost see the cornea through the upper lid skin. Mechanical ptosis is easy. Any patient with lid inflammation, lid tumor, lid mass can cause mechanical ptosis. Now let's go into congenital ptosis, which is the most common type. To evaluate a case of congenital ptosis clinically, you have to go through all these points. Don't be scared, we won't go through all of them. We'll just go through the most important, which is the margin reflex distance. That will give you an idea about the degree of ptosis, either mild, moderate, or severe ptosis, the vertical fissure height, the upper lid excursion, or in other words, the levator function. And according to the levator function, this would help you decide the type of surgery that you're doing to the patient. The position and the presence or absence of a lid crease. Lid crease can be totally absent, which is a sign of poor levator function. It can be a double crease. It can be asymmetrical crease. So you have to comment on the lid crease, and the better crease you have, the single, better, well-defined crease, this is a good indication of good levator function. Either the child has epicanthus or telecanthus, so you'll have to address this also in your surgery. And if the child has an abnormal head posture, sometimes children with unilateral ptosis would tend to tilt their head, which we call head tilt, or the children with bilateral ptosis will tend to elevate their chin in order to see through the dropped eyelid. So you have to check all this. Either the child is performing brow elevation or not is also important, and it gives you an idea about the child's behavior after surgery. If you do a frontalis sling and you have a child already elevating his eyebrow and using his frontalis, so he'll be happy after the surgery and he won't have problems using the frontalis muscle. And it's not relevant whether in unilateral or bilateral. We see here this child, sorry, 2 minutes, come in. If this, as you see, this girl is having unilateral ptosis, you would say she don't have to elevate her eyebrows or over function her frontalis because she's seeing with the other eye. But here as another example of unilateral ptosis, and the child is using her frontalis muscle. So let's go into surgery. What would you do? We have 3 main surgeries. The first one is conjumalectomy, but you have to do conjumalectomy, you have 2 conditions. The first is mild ptosis, 1 or 2 millimeters of ptosis, and the second is positive phenylephrine test in your clinic before surgery. So it's done transconjunctival, no skin incision. It's very nice. The results are very consistent if you have these 2 conditions. The second surgery is the levator surgery, mainly the levator resection, and actually I don't do levator resection anymore. I replaced it with levator tucking, which I think is more safe, and it has the benefit of being reversible. You don't be scared of overcorrection or undercorrection. You can just go back and adjust the height of the levator, since you did not cut any part of the levator aponeurosis. The third surgery in cases with poor levator function, seen here by absent decrease, and here we can do frontalis suspension. The best thing, of course, is to do it through fascia lata, but you can also use synthetic materials. And here you would think of something. Can you do frontalis suspension in unilateral cases, and would it be a good option or not? Actually, yes, it's a very good option, even in unilateral cases. Regarding that, you just have to adjust the height. It's very useful, and you don't have that feared asymmetry. Of course, you will have some asymmetry, especially when the child is looking downwards. You would have some lid lag in the eye that you are doing frontalis suspension. But in most of the cases, it works very well. The last aspect that I would like to talk about is the psychological impact of ptosis surgery on the child. This child, his mother said he was usually angry, annoyed. After the surgery, he got calm. He got happy. This child is, whenever he comes to my clinic, he's so sad. I get depressed whenever he comes. After the surgery, he's much more happier. Fadi from Gaza, they sent me his pictures in the kindergarten before surgery, and he's usually lonely and having no friends, and said after surgery he was absolutely happy. Actually, I didn't hear from him since the war, and I hope he's okay. Thank you.